Good afternoon, everyone, and welcome to this Endo-ERN webinar. Thank you for taking the time to join us today. We have a really interesting program with international expert speakers from within our network. To start, I'm going to cover some housekeeping. You're currently in listen-only mode, with the exception of our speakers who should mute themselves if they're not presenting. And you are free to type in the chat if you have any questions during the course of the webinar, but we'll actually take all questions at the end. The speakers will take them then. And at that time, I will unmute. You can raise your hand if you want to ask your question directly to one of the experts, and then we can unmute you. But for now, I'd like to dive in and would briefly introduce our chairs. Professor Nienke Biermasz is Professor of Internal Medicine at Leiden University, and she's a top specialist in multidisciplinary aspects of pituitary disorders. In addition, Professor Biermasz is the main representative for Leiden University Hospital to Endo-ERN, and she's also chair of the main thematic group covering hypothalamic and pituitary conditions. We have the pleasure of another chair, Professor Irène Netchine. Professor Netchine is professor at the Sorbonne University Trousseau Children's Hospital, and she's a pediatric endocrinologist, also with a specialty in multidisciplinary aspects of care, particularly for patients with Silver-Russell and Beckwith-Wiedemann syndrome. She is the pediatric chair of Endo-ERN's main thematic group 5, which covers growth and obesity syndromes. On behalf of Endo-ERN, I would like to thank you both for taking the time out of your busy schedule to chair this webinar. And for now, I turn it over to you.
Yeah, thank you, Amy. I'm Nienke Biermasz, and well, this webinar is organized by main thematic group 5 and 6 together. It was an initiative by Gudmundar Johansson, well, who will be probably somewhere in the audience today. And well, we would like to to merge the two interesting topic of the both main thematic groups, so the hypothalamic disorders and the obesity and hypothalamic obesity part of the MTG5. And well, I think we have a very attractive program, as you have probably seen on the introduction. And it is a pleasure to first introduce Wei Gan from Great Ormond Street Hospital for Children. He's a lead of the neuroendocrine service for children with brain tumors and a deputy chair of the UK National Pediatric Craniopharyngioma Guideline Development Group. And well, maybe let's just kick off with the content. And we will do the Q&A. I think, Amy, you already said it, after the sessions.
Shall I start?
Yes, please start if it's fine with you. And good morning, good afternoon, everyone.
Thank you, and thanks, Nienke and Irène, for letting me talk about this topic. So I'm going to talk about the pathophysiology of hypothalamic obesity, and I've deliberately put craniopharyngioma patients in small fonts because obviously hypothalamic obesity it doesn't just affect craniopharyngioma patients, it affects patients who've got any kind of supracellular damage, really. So really, hypothalamic obesity is not a new concept. It was first described by Babinski and Froelich in the 1900s. And they both described a syndrome of what they called adipocegenital dystrophy. And there were two separate cases of a girl and a boy, both who presented with headaches and visual impairment. They had short stature, delayed puberty, and they were overweight. And it was also described that the fat distribution was very centripetal. Obviously, at the time, they didn't have treatments for brain tumors, so both of these patients died, and in the post-mortem, they both had a suprasellar mass. So obviously, over the years, our understanding of hypothalamic obesity has really evolved over time. So some of the first experiments in rats, where they induced lesions in the hypothalamus and pituitary gland, that was when they showed that the hypothalamus was really responsible for appetite and weight rather than the pituitary gland. And then about 10 years later, further studies actually showed that it was the ventromedial hypothalamus that was particularly crucial for appetite and weight regulation. Another 10 years later, the first description of the spontaneous breeding of OB mice, which of course we now know as the leptin deficient mouse, was first described. And just remember that these were actually the results of a spontaneous breeding between the mice. It wasn't something particularly experimental, and it was described that these mice were actually only bred in a 1:4 ratio, so an autosomal recessive pattern. And then it took really about 40 years before the advent of molecular genetics allowed us to clone the OB gene product, and obviously that was when leptin was discovered. And then quite rapidly after that, we first described, well, not we, but people first described the first case of human congenital leptin deficiency and the first successful therapeutic trial of leptin. And you can see that well recognizable photo of a boy with leptin deficiency who was treated, and the big difference in his weight afterwards. It's also important to remember that actually we think of leptin as the first appetite regulating hormone, but actually many of the other hormones in the circuits I'm about to show you were really described and discovered much earlier than that. So what is hypothalamic obesity? Well, it's been really loosely defined as a syndrome of intractable weight gain after any hypothalamic damage. We all know that there can be associations with this, which we call the hypothalamic syndrome. So patients can have hypopituitarism, they can be significantly hyperphagic, they might have temperature dysregulation, sleep-wake cycle disturbance. More rarely, some of them have autonomic dysfunction and also behavioral difficulties, which often can mimic syndromes like autistic spectrum disorder or ADHD. This is really a very rough calculation of the potential estimates of how many patients of different suprasellar lesions become obese over time. And you can see craniopharyngiomas, about nearly 4/5 of them, possibly more, actually become obese if you follow them up for a long enough period. So every time I look at this circuit, this is the expression I get, really. I'm sure you all have the same expression because the circuit is very complicated around appetite regulation. But I'm going to try and attempt to take you through a bit of a tour around this circuit, just so we have some basic understanding of what our normal appetite regulation pathways are and how that potentially could be disrupted in hypothalamic obesity. So the way to think about it is our networks are really in two states, so either the fed or fasted state. And in the fed state, I've deliberately colored it red. You've got all these hormones that tell your body to stop eating. And then in the fasted state, where the traffic light's green, your body's allowed to eat. And you can see there's a slight imbalance between the number of those hormones on the kind of appetite suppressing side versus the appetite permitting side, and that's to tell you basically our bodies are really driven to eat, and we need a lot of circuits to tell our bodies to stop eating, so the brakes on the circuit. So just highlighting a few of the main hormones in these circuits. So insulin is really the first appetite regulating hormone that was first described, even though we don't really think of it that way. We all know that insulin is made by the pancreatic beta cells. It is stimulated by high blood glucose readings and inhibited by low blood glucose readings. So, we understand that as fairly simple. We know that actually insulin, in terms of appetite regulation, signals to the arcuate nucleus, which is really important in controlling how much we eat and our body weight. And we'll talk a bit more about that later. So in the arcuate nucleus, it stimulates the conversion of pro-opiomelanocortin to alpha melanocyte stimulating hormone, or alpha MSH. And in return, it also inhibits neuropeptide Y and a gluteolated peptide. Like I say, we'll talk about those circuits in a bit more detail later. So the next appetite regulating hormone, which we've already briefly discussed, is leptin, and it signals via the leptin receptor. And you can see it there. It is made by white adipose tissue, and the kind of isoform of leptin that's important for appetite regulation is called, of leptin receptor that's important for appetite regulation is HLR274. It stimulates feeding, it is stimulated by feeding and inhibited by fasting and starvation. And again, it targets the arcuate nucleus, but also other hypothalamic nuclei, such as the ventral medial nucleus, the lateral hypothalamic area, dorsal medial nucleus, and paraventricular nucleus. In terms of its outputs, again, it stimulates POMC to alpha MSH conversion, and like insulin, it also inhibits NPY and AGRP production. So the next important appetite suppressing hormone that I'm going to be talking about is GLP-1, which signals through the GLP-1 receptor. That's obviously a very popular hormone nowadays, particularly with obesity, as you all see in the recent randomized control trial where GLP-1 agonists have been shown to work really well for common obesity. So GLP-1 is made by the small intestinal L cells, but also made in the nucleus tractus solitarius in the brainstem. So you can see where they're made there. And GLP-1 is called glucagon-like because it's actually made from the breakdown of proglucagon, which is broken down to glucagon, GLP-1, and GLP-2. It is an incretin, so it's stimulated by glucose, and it is broken down by DPP-4, and therefore inhibiting its action. It targets various hypothalamic nuclei in the brain, including the arcuate nucleus. It's also important to realize that GLP-1 signals to the NTS, where it is also linked up with things like vomiting centers and also higher centers in the cerebral cortex related to pleasure associated with eating. GLP-1 directly stimulates weight loss, and as an incretin, it increases insulin production, but also insulin sensitivity. It actually stimulates other hormones such as CRH and oxytocin, which are known to have roles in appetite suppression. In return, it also inhibits appetite. It inhibits gastric emptying. So patients who take GLP-1 agonists will often describe a bit of nausea and sometimes vomiting. And it modulates the interaction between NPY and AGRP versus alpha MSH and CART. And then the other peripheral hormone I want to talk about is cholecystokinin, which acts via the CCK-AR receptor to inhibit appetite. It is made again by small intestinal L cells, but actually it's made throughout the central nervous system and the nucleus tractus solitarius again. Cholecystokinin is broken down as a byproduct of the breakdown of pro-CCK, and the important isoform for appetite suppression is CCK8. We know that cholecystokinin is actually stimulated by the presence of food in the intestines, particularly fat and protein. It is actually inhibited by GLP-1 in a kind of more peripheral negative feedback circuit, and it's also inhibited by somatostatin. Again, it targets the NTS and the area postrema. It's important to realize that in the area postrema, which is your vomiting center, is blood-brain barrier deficient. It also targets the stomach and gallbladder, as well as all these other hypothalamic nuclei. Importantly, it stimulates the alpha MSH and MC4R receptor interaction and inhibits gastric emptying. And again, cholecystokinin can induce vomiting as a result and inhibits appetite. And then before I talk about the central hypothalamic hormones, the last peripheral hormone is peptide YY, which is made again by intestinal L cells, but also in the pancreas. It is made by the conversion of PYY136 to 336, and that's important because it is this form that crosses the blood-brain barrier. A bit like CCK, it is stimulated by food intake, the presence of digested food in the small intestines, and it's inhibited by fasting. It targets the GI myenteric neurons, so it controls peristalsis, and then again various areas in the hypothalamus, the brainstem, and the vomiting centers. It stimulates POMC production. That's how it suppresses appetite, but it also stimulates the sympathetic nervous system to encourage the body to burn off calories. It inhibits NPY, which is an appetite permitting hormone, and also gastric emptying. And then this is the center in the hypothalamus, in the arcuate nucleus, which is probably the most important center for appetite suppression, because you've seen all these different peripheral hormones actually signal to this region and actually influence alpha MSH and MC4R. So POMC is made by the arcuate nucleus. It is again a very long prohormone, and it is actually a prohormone of ACTH and also beta MSH, which is responsible for melanin production, and as well as your endorphins. Alpha MSH, in order to interact with MC4R, it is also potentiated by something called CART, which is the cocaine amphetamine regulating transcript. And both of those stimulate MC4R to reduce appetite. So the conversion of POMC and alpha MSH is stimulated by leptin and insulin, but also other peripheral hormones such as PYY and CCK, and it is inhibited by AGRP production. So it targets other hypothalamic nuclei such as the paraventricular nucleus, dorsomedial nucleus, and lateral hypothalamic area. Importantly, it also signals to the locus coeruleus, which is the source of our sympathetic nervous system, again telling the body to burn off fuel that it's eaten. And like I say, it stimulates energy expenditure, so glycogenolysis, lipolysis, thermogenesis. It also stimulates other appetite suppressing hormones such as TRH, CRH, and oxytocin, and it inhibits appetite and actually negatively feedbacks on insulin production. So on to the orexigenic hormones, of which there are very few really. So these are appetite permitting hormones. Ghrelin is obviously the most well known. It is made by the oxyntic glands in the stomach, and in order for ghrelin to work, it needs to be acylated. It is stimulated by fasting, and in Prader-Willi syndrome, the opposite thing happens. They've got actually a raised ghrelin, which is thought to stimulate their appetite. It is inhibited by feeding. So a bit like the opposite version of leptin, basically. It targets the arcuate nucleus, as well as the area postrema and the pituitary gland, and that's important because ghrelin is actually a really strong stimulating factor of growth hormone production, and actually stronger than GHRH even. And then ghrelin stimulates growth hormone production. As I say, it also stimulates AGRP and NPY, and also appetite and weight gain. It inhibits POMC and CART, and it inhibits lipolysis. So AGRP and NPY, so these are actually antagonists of the alpha MSH CART system. So it antagonizes the MC4R receptor, and it's made by the arcuate nucleus as well as adipose tissue. It's stimulated by fasting in ghrelin, and it's inhibited by leptin and insulin, unsurprisingly. Targets of these hormones are the lateral hypothalamic area and the nucleus tractus solitarius, as well as the amygdala and higher centers such as the nucleus accumbens, which again regulates the pleasure centers associated with eating. So these hormones stimulate appetite. It also stimulates the vagal nerve, which is obviously the source of a parasympathetic nervous system, which slows down all the metabolic systems in the body and therefore causes storage of the calories. It inhibits MC4R directly. It also inhibits gastrointestinal motility and also energy expenditure. So that's just a whistle-stop tour of all the different hormones, and this is just a quick summary of how the circuit works. So on the left, in the fed state, you get an increase of leptin and insulin, and also GLP-1 and CCK and PYY, and all of these ultimately signal to the arcuate nucleus, which then produces alpha MSH and CART, which then signals to the MC4R receptor, and it tells the body to basically burn off fuel through the sympathetic nervous system, and it suppresses appetite. Contrastingly, in the fasted state, you have increasing ghrelin from the stomach, which directly stimulates appetite via the arcuate nucleus, and then you get production of AGRP and NPY, which in turn causes the opposite reaction and storage of calories and weight gain. Those are just the main hormones that involve in appetite regulation. I've not really talked about other hormones such as BDNF, oxytocin, and nesfatin, as well as orexogens such as hypocretin, orexin, MCH, and adiponectin, because there's just not enough time to talk about all of them. So this is what we know about hypothalamic obesity. We don't really understand why it happens. But the first thing to say is that hyperphagia, or increased appetite, is not really essential. So this was a study that's a bit old now, looking at food diaries and the intake of food from various craniopharyngioma patients. And you can see that actually the patients with hypothalamic involvement of their craniopharyngioma, they actually ate less than the controls, even though they had a higher BMI, and they also ate less fat. So it tells you something about the way they burn off food. And additionally, they actually moved a lot less compared to controls. However, when we talk about that, we also know that in genetic obesity syndromes, hyperphagia is actually a classical feature. So it is fairly clear that actually in structural causes of hypothalamic obesity, it's a bit, it's not as clear what the cause of the weight gain is. People have also thought whether autonomic dysfunction is present, and the jury's really out, because studies that have looked at things like epinephrine and norepinephrine or adrenaline have really shown mixed results, because no one's really sure whether there's a reduction in the production of these hormones. But we do know, however, that the resting energy expenditure in a lot of these patients is lower, so they are burning off their food less quickly. And then the role of hyperinsulinemia. So there's two theories behind this. One is that you damage your hypothalamus, that impairs your appetite centers, that causes weight gain, and that in turn causes insulin resistance and a raised insulin. And we know that insulin is a growth factor. The opposite theory is that you damage the hypothalamus and you inhibit your vagus nerve output, which actually innervates your pancreas, and that causes hyperinsulinemia and obesity. And this is what led to a previous trial using octreotide, which is a somatostatin analog, which reduces insulin secretion, and looking at how it affected weight gain in these patients, and it did have some effect. So there's probably some truth behind that theory. However, the hypothalamic damage in patients with suprasellar lesions, such as craniopharyngiomas, is really quite heterogeneous. So if you look at the structure of the hypothalamus and the location of these appetite regulating centers, you can see that they're kind of towards the back of the hypothalamus and near the mammillary bodies, which kind of sit between the hypothalamus and the pons. And if you look at an MRI, you can actually see that the mammillary bodies, which are really where the label 3B is quite close to the posterior hypothalamus. So if you've got damage of the mammillary bodies, from a craniopharyngioma or from any other lesion or from surgery, then you're more likely to develop hypothalamic obesity. But obviously, when you've got structural damage, the damage can be quite heterogeneous, and that's what makes it quite unpredictable in terms of figuring out which pathway is involved in causing weight gain in these patients. So there have not really been many drugs for treating hypothalamic obesity, and really there have only been 2 successful drugs so far. So leptin for leptin deficiency and setmelanotide for these other indications. And these are all obviously genetic obesity drugs, and no one's really used them for acquired causes of hypothalamic obesity. And people have tried all sorts of things over the years to try and get these patients to lose weight, and no one has really been successful in causing long-term weight loss. And some of these drugs, such as sibutramine and beloranib, have now been withdrawn from the market due to side effects. So really, that's the end of my talk. In summary, there's obviously significant redundancy in the appetite regulating pathways, particularly in the appetite suppressing pathways in the hypothalamus and the peripheral glands that produce appetite regulating hormones. And therefore, the pathophysiology of hypothalamic obesity involves more than one mechanism, particularly because the structural damage can be quite heterogeneous and quite difficult to describe. We don't really have good MRI techniques to kind of delineate which nuclei are affected to date. And therefore, patients with hypothalamic obesity are really quite heterogeneous in terms of treatment and in terms of the cause of hypothalamic obesity. So there's no one size fits all in terms of managing these patients. So thank you very much for your time. I'll be back to answer questions later on the panel. But that was really quite a whistle-stop tour of hypothalamic obesity. Thank you once again.
And thank you very much, Hongwei, for this very nice and complete overview of this complex matter that we'll discuss at the end.
Thank you.
Yeah, we move forward to the next presentation of Hanneke van Santen. Well, Hanneke van Santen is a pediatric endocrinologist. It's a network worker. Since she's working both in the Wilhelmina's Children's Hospital in Utrecht and in the Princess Maxima Center for Pediatric Oncology, specialized in the endocrine consequences of childhood cancer treatment and also pediatric thyroid cancer and childhood craniopharyngioma. She had a very fascinating conference last year on the topic of hypothalamic obesity, and well, she's chairing several working groups in the field of craniopharyngioma and childhood cancer. Well, her research is focusing in this topic as well. So, give the floor to you.
Thank you so much, Nienke. Can you hear me well? Great. And do you also see my screen?
Yes.
Super. Great. Thank you so much. Well, thanks so much for the invitation. And the excellent talk of Hong Wei was an excellent introduction, because now we know what is the etiology of hypothalamic obesity. Of course, the question is, how should we treat it? And that's what I will be addressing. And I think the most important take-home message is that hypothalamic obesity in patients with craniopharyngioma need individual treatment. And I think the first take-home message of my lecture is that hypothalamic obesity is not just obesity. And I think the studies that Hong Wei showed that often the results are very disappointing is because all studies are addressed at treating the obesity. Well, in fact, patients with craniopharyngioma have hypothalamic dysfunction, and obesity is just one of the symptoms. Patients with hypothalamic dysfunction can have pituitary gland dysregulation, behavioral problems, disturbances of the circadian rhythms of sleep. They can have hyperphagia, but as Hong Wei addressed, not all of them have it. They can have a low energy expenditure, and they can have temperature dysregulation. And it's necessary to address all these issues if you treat a patient with hypothalamic obesity. And this takes me to my second take-home message. Hypothalamic obesity is not one size fits all, because the hypothalamic dysfunction lying in the background of this obesity can be very different. To illustrate, I would like to present two patients of me. This is a girl who had a craniopharyngioma at age 4. She presented already with obesity and also with headaches. She was diagnosed with craniopharyngioma and was treated with a complete resection. And she was cured oncologically or from the tumor. But then the problem starts. And this is actually the sentence of the mother, which I quote, "Yes, she survived, but is she really cured? And I, in fact, did lose my daughter, although she's still here." And this is, of course, very impressive when a mother talks about her own child like this. But it does illustrate the magnitude of the problem, because the girl now is morbid obese with severe cardiovascular morbidity, type 2 diabetes. She has very severe hyperphagia, panhypopit, with diabetic insipidus. She does have a very adequate thirst regulation, so that's very good. She does have disturbed day-night rhythm, waking up early in the morning. She has a normal temperature regulation, a normal vision, but very severe neurocognitive deficits. She rages, she lies, she steals food, and this family needs 24/7 video surveillance of the child, and family life is really disrupted. For this girl and family, the most important problems are her behavior, her severe hyperphagia, and the morbid obesity. But this is another patient of mine. This is not a craniopharyngioma, but also a tumor in the suprasellar region, a low-grade glioma. This boy actually presented with failure to thrive and a nystagmus. He was treated with debulking and a VP drain, had a second debulking at age 2, and was treated with chemotherapy. And he now has a stable disease. However, also hypothalamic obesity. He also has a panhypopit and diabetic insipidus, but he has an inadequate thirst regulation. This means that the parents have to monitor the fluid intake and output 24/7 and measure the sodium levels. He has a disturbed day-night rhythm, always wakes up at 4 in the morning, is very sleepy in the day, and he has a severe hypothermia. So his temperature can go down to 34 or 33.5 degrees. He's blind, he has severe neurocognitive deficits, and he has epilepsy. So also for this family, it's a 24/7 care situation with a disrupted family life. And for him, the most important hypothalamic problems is also the obesity, but also sodium regulation and hypothermia. Because it can be difficult if you have a patient in your room to see what's really the underlying problem, together with some colleagues and Professor Müller, we have defined a scoring system for signs of hypothalamic dysfunction. And this will be published in the European Journal of Endocrinology, I think in the coming weeks. And I hope you all can use this in your in taking care of these patients to define the different domains of hypothalamic dysfunction, and we defined a score for defining the hypothalamic syndrome. And this can not only help us in care, but also in research purposes, because actually we don't know the prevalence and the severity of the hypothalamic syndrome of hypothalamic dysfunction in these patients. And this is because the incidence and prevalence are related to very rare underlying diseases, but also because for a lot of us have focused on the obesity, but not on the other signs and symptoms of hypothalamic dysfunction. Now, we've already assessed this score in a Dutch and German cohort, and this is a lot of numbers, you don't have to look at it, but if you then look at the presence of the hypothalamic syndrome in craniopharyngioma patients, it's around 50%. If we then zoom in on the obesity, for this small cohort, we found 18 with severe obesity. And if you then look at the different signs and symptoms of hypothalamic dysfunction, this exactly illustrates the problem. Some have major hypothermia, some have it a little bit, some don't. 5 had major hyperphagia, 6 had a little bit hyperphagia, but 5 didn't at all. Half of them have a decreased resting energy expenditure, but the other half doesn't. So again, this illustrates that you should characterize your patient to see which treatment better fits your patient. To think about this problem, the hypothalamic obesity, by personalized medicine or in an individual way, started actually several years ago, and we did a review on all the treatments available for hypothalamic obesity following craniopharyngioma or other suprasellular treatments. And in this review, we found what Hong-Wei was saying, that there were a lot of studies done, but most included studies show limited effects of intervention. However, if you look closely to the studies, you always see there are some responders and some non-responders to treatment. And if we were to define the responders of each treatment, then perhaps we can develop adequate treatments for those patients who fit the responder group. And the reason that it's so different is because the damage of the hypothalamus depends on which nuclei are destroyed. So treatment is not one size fits all, but must be individualized. Now, if we go back to the hypothalamus, and this is a simplified scheme, which I adapted from the publication of Dr. Lustig, you see that when the hypothalamus is damaged, the signs coming into the hypothalamus aren't sensed well enough. So these can be neural signs from the vagal nerve or the hormonal signs. Also, the efferent pathways of the hypothalamus are distorted. So the efferent signals stimulate the sympathetic nervous system, which increase your energy expenditure, which decrease your vagal nerve, reduces insulin secretion and promote lipolysis, and this all decrease appetite and decreases your energy expenditure. So in fact, this resembles an organic leptin resistance with increased food intake, decreased energy expenditure, and increased energy deposits. But then when we talk about the craniopharyngioma patients, they will also have, to more or less extent, vision loss, behavioral changes, hypothermia, disturbance of the circadian rhythm, hypopit, fatigue, and all these symptoms add on and lead to the morbid obesity. So we defined this algorithm, which you can use to characterize your patient and stepwise see which treatment is necessary and which treatment can help your patient. And I think the third take-home message is that you need a team to do this, to deliver this care to the patients. And this is my team. I'm very lucky to have such a team. And I think that if you work in a hospital where you don't have such a team, please refer your patient with hypothalamic obesity or discuss your patient with an expert team so that your patient gets the care or treatment that he deserves or she deserves. So if we go back to the treatment algorithm, the first domain is psychosocial. So we see neurobehavioral dysfunction in more than 50% of patients with craniopharyngioma. This can be behavioral, but also impaired social, emotional, and neurocognitive functioning, of course, reducing quality of life. And this is explained by damage to the connective circuits that are there between the limbic system and the hypothalamus. And the hypothalamus is an essential part of this limbic system. And the hippocampus-centered network is essential for your episodic memory, and the amygdala-centered network is relevant for your social-emotional functioning. So these patients with these behavioral problems, they need specialized psychologists and psychiatrists. We do not encourage hospitalization, because you need to create the home setting, of course, for the best guidance. And I think we do need more studies to better predict and understand these behavioral problems so we can better treat it. Some studies have, of course, been done, of which I think most importantly those with oxytocin, which do show some positive effects on emotion perception, but I do think we need more studies to address this. So the second domain is the hyperphagia. This can be very severe and, as already said, not present in all. First, education. I think if you tell your patient why the patient is always hungry, it helps to understand, and it may also help to not listen to their hyperphagia all the time, which is very difficult, of course. Lifestyle and diet is a cornerstone of any obesity, but also of hypothalamic obesity. And then if pharmacological intervention and bariatric surgery. So first about lifestyle and diet. So it needs to be early, it needs to be intensive. In the review we wrote, we found 5 studies with about 50% positive results. There's hardly any evidence for which diet you should choose. We feel there's some evidence for prescribing a diet with high proteins, low carbohydrates, and you can use your resting energy expenditure measurement to calculate the calories that your patient burns. Essential here is the home environment. This is an example of a patient of mine who has a very low energy expenditure, but a very strong mother. And this mom feeds her vegetables, and puts her daughter on a home trainer 3 times a day. And you can see that lifestyle can also be a very good treatment for hypothalamic obesity. This is another patient who I admitted to hospital for a period of 3 months, and we just gave lifestyle and a diet, and you can see her losing weight. But you also see that as soon as we dismissed her from hospital, her weight increased again. So this was not a good idea, actually, because you cannot, of course, admit her to hospital all the time. So I'm not saying that parents aren't strong enough, because these are 2 patients of mine with a very strong home environment, excellent parents, and sometimes it's just not something you can treat with lifestyle and strong home environment. So these children have severe hyperphagia, behavioral problems, and a strong home environment. So then you need other treatments. So what pharmacological treatments are there? And Dr. Neggers will talk about GLP-1, so I will be very short. This is a satiety hormone, and I will just very shortly show our very small cohort. We've given this to 5 children with I thought disappointing results, but this was 2 milligrams exenatide subcutaneously. But these patients experienced a lot of side effects and not really weight loss. But we will hear about that later. So what if drugs don't work? What about bariatric surgery? Bariatric surgery reduces your food intake because your food choice and your taste and your motivation changes. There was a very nice review done by our colleagues in Rotterdam, and it does appear to be effective and safe for obese craniopharyngioma patients who did a multi-center study of 16 patients and showed a mean weight loss at 5 years of 22% with no major change in endocrine replacement therapy. So this seems promising, but I do think we have to be careful at the pediatric age, but this can be something for the adult patients. future developments, together with a student, we looked into the possibility of deep brain stimulation, which can be given to patients with obsessive compulsive complaints and also for obesity. In total, this has been reported in literature in 6 patients, of which 1 had craniopharyngioma. Now, we did see a decrease of the BMI in the craniopharyngioma patients, so this may be something to further explore by the neurosurgeons. So the third domain is about the circadian rhythm. We all know that if you have a bad night rest, you're hungry, you're tired, you're less prone to exercise. And this is, of course, also for our hypothalamic patients. Our patients can develop primary hypothalamic sleep dysfunction, so hypersomnia, narcolepsia. They can develop disturbed sleep-wake cycles, but they can also, of course, have secondary sleep disturbances. Because of their obesity, they can develop the obstructive sleep apnea syndrome, but they can also, for instance, have a badly regulated diabetic insipidus with urine output in the night, or stress, or just simple hygiene, being on their iPhone too late at night. So this is something that you need to ask and check with your patient. And together with a PhD student, Jiska van Schaik, we wrote a diagnostic algorithm you can use to have a stepwise approach to address these sleeping problems. The fourth domain in our algorithm is to address the energy expenditure in your patient. And if you want to objectify this, you can use indirect calorimetry. And you can measure the resting energy expenditure and calculate how many calories should your patient eat. Now, we see that the energy expenditure can be lowered. And if it is lowered, there are several ways to increase it. First of all, is long-term training. If you increase your lean muscle mass, you will increase your energy expenditure. Secondly, ask for or measure temperature a few times a day and see if there's hypothermia. Because if you have a low body temperature, your energy expenditure will go down. So for these patients, you can advise active heating. And another note, not for the obesity, but you should also increase your hydrocortisone in the very hypothermia patients. Patients with pituitary deficiencies, you can also use your endocrine suppletion therapy to increase your energy expenditure. So patients with a growth hormone deficiency should be treated. You can increase your IGF-1 concentration, you can increase your thyroid hormone concentration, and you can timely start your testosterone suppletion therapy. Of course, all within the reference ranges, and you shouldn't aim for a too high level of the hormones, but it should be supplemented well. For patients who have a decreased resting energy expenditure, there were already some reports about amphetamine treatments. And this is something we looked into also together with the Rotterdam group. And in total, we treated 17 children, of which 13 non-genetic, so with a brain tumor. And we found actually a very good response in some, not in all again. And 13 patients in total reported decreased hyperphagia, improvement of energy level and or behavior. And in 14 of the 17, we found a BMI decline or even stabilization. And these are 3 patients who were included in that cohort. And you see patient A and B being excellent responders. At the green arrow, you see the start of the amphetamines. You can really see a very nice response. But you can also see in picture C that not all patients, again, respond. So you have to address carefully which patients you want to treat with amphetamines. And to measure your resting energy expenditure can be a very good way to distinguish those who will benefit or not benefit from amphetamine treatments. So the 5th domain is the hyperinsulinemia, which can be present because of the reduced vagal tone, and this results in an increased storage of fat and also hunger feelings. If there's also type 2 diabetes or presence of hyperglycemia or acanthosis nigricans, so the dark spots on the skin, you could choose metformin, and other options that have been studied are diazoxide, metformin, octreotide, but also we'll come back to GLP-1 with this aim. And the last domain is the hypopituitarism. This is of course very frequent in the craniopharyngioma patients, and all children and adults should be supplemented for their hypopit because inadequate treatment affects your fatigue, headaches, activity, but also your BMI. Just a few points. Growth hormone in craniopharyngiomas patients is safe. We recently reported in this new consensus statement that we feel growth hormone can be already given 3 months after the diagnosis. And I think if we address obesity, it is very important for its metabolic effects and muscle mass. Central hypothyroidism can be mild. If you see your free T4 decline over time while it's still within the reference range, it may already indicate a central hypothyroidism. And regarding central hypocortisolism, it's important to note that there has been shown that patients with central hypocortisolism may have upregulation of the 11-beta-hydroxysteroid dehydrogenase, and this increases your cortisone to cortisol conversion. And this means that these patients can have lower hydrocortisone doses when you compare them to like Addison patients, and this may also positively influence their BMI. So this is in very short the treatment algorithm, which you can find in endocrine reviews. So just to summarize, hypothalamic obesity in craniopharyngioma patients is not just obesity. Don't just focus on obesity, but focus on the total picture of hypothalamic dysfunction. It requires individualized treatment. It needs referral to an expert center or at least discussion with an expert center. It requires multidisciplinary approach and perhaps the characterization in the 6 domains can help you to make an individual treatment plan. So thank you so much for your attention and the invitation to talk today.
Well, thank you very much for this very good talk. And so we'll take the question after. And now we are going to listen to Johan De Graaf. Johan is involved in the Dutch Pituitary Foundation for over 10 years and is chair of this foundation since 2015. From the start, he has been really active for the Endo-ERN, and in recent years, he has ascertained the unmet needs in endocrine and pituitary patients by means of multilingual surveys. So in this webinar, he will discuss the result of a survey targeting patients with hypothalamic dysfunction diagnosed during childhood. So, Johan, we are
thank you.
listening to you now.
And now you see I'm struggling with my screen. Why? Amy, help.
Okay, let me make you the presenter again.
Where is the screen?
Maybe in the meantime, if there is one question, if I may make use of the opportunity to have one question to Hanneke, maybe, because you're doing personalized medicine, and I don't think it's the way that word was invented, because it's trial and error, isn't it? But it's because we don't have the opportunity to predict what is going to work. I think it's very important to measure outcomes and effects of trials, isn't it? How do you have your protocol for that?
Yeah, it's a very good question, Nienke. No, you're right. So it's not what I meant was that I think that the reason that all the results have been so disappointing on drug interventions for hypothalamic obesity is because it's now often advocated that the patients with hypothalamic obesity, and I don't think there is the patient with hypothalamic obesity. I think that there are many different kinds of patients with hypothalamic obesity, and by identifying the underlying additional problems, then perhaps if you really identify the patients really well, GLP-1 will work in 90% of the patients that are selected. Or amphetamines will work very well in 80% of patients if they're well selected. So I think in this regard, and I hope this new scoring system we made will help to identify the patients and characterize them more, and so we can compare them. And then finally, combine cohorts to make larger numbers, because of course it's still a very rare disease.
Okay. Well, your last phrase is it was muted, but thank you so much. A lot of work to be done.
Yes,
We continue
absolutely.
with Johan. I think your slides are ready.
Yeah, you see my screen or not?
Yes.
Oh, okay, fine. Now, thank you for the invitation. And now it's gone. Why is that?
No, it's here.
I don't see it. What?
Would you like me to project, Johan?
Yeah, it disappears. And maybe it's because it's a full screen.
We could see it, Johan.
Okay. Okay, now I see it again. We issued a survey starting last year in April 2022, and we collected data up until September 30th on patients which are at an age of diagnosis 18 years old or younger with craniopharyngioma, gliomas, and germ cell tumors. We made a survey available in 13 languages, and we used machine translations via DeepL.com, and they are checked by native speakers from a network of patient representatives and also from healthcare providers from the Endo-ERN network. The dissemination followed through patient groups, references of Endo-ERN, and of course, healthcare providers. My screen starts popping off. I don't know what it is. We had also the cooperation of a few charities sharing our link, and that really gave a boost to the number of people responded to our survey. The survey should be filled out by patients, carers, or patients together with their parents, the carers. And we were looking for the unmet needs of Amy. I think it's better that you will share it because I am thrown out every time.
Okay.
We were looking for the patient's unmet social and medical needs, and also asking for suggestions for future medical research. When you look at the European contributions, Germany really stands out. That was because of Professor Muller shared our link personally with his patients. And otherwise you see that also the Netherlands is scoring very high, and also the UK. Those are also the three biggest pituitary foundations in Europe, but also France and Italy and Norway. And that's because of we have patient representatives in our network also knowing to reach out to patients. But you also see that when there isn't a patient organization, it's very difficult to reach out to those patients. So you see the number of Eastern European contributors is very low. And well, that's real shame. And you see that you need an infrastructure of patient organization to reach out to patients. I was also talking about the international charity who give our survey a boost. You see the number of responders in North America and in Canada, and even in some countries in Africa, Japan, the Philippines. That was a real surprise for us, and also offering us interesting data. When you look at who filled out the survey, you see that 60% of surveys were filled out by the patients themselves, 24% by the patient's parents or carer, and 16% did it together. And we also asked for the current age, and we have seen 64% is above 18, but we asked those patients if their diagnosis was before the year of 18. Looking at the conditions, it's 78 craniopharyngiomas, and also a small number of other tumors were reported. And the gender is almost 50-50, so as we expected. Another question we asked is how much time was there between the first symptoms and the final diagnosis? And it's fine to see that over almost 40% of the patients had the diagnosis within 6 months of the first symptoms. But you also see that the number of patients struggled for more than 5 years, 4 and 5 years. So those percentages are worrying for the patients that have to wait so long for their diagnosis. And also we asked how much effort it took to find a doctor. And it's nice to see that almost 45% said, well, very little or little. But you also see that 20% had to struggle to find the right doctor, and even more than 15% had to switch doctors to find one that would be able to help them with their problems. When you look at the hormonal deficiencies, you see that the majority of patients has hypothyroidism, and 70% vasopressin deficiency, 77 sex hormone deficiency, almost 81% growth hormone, 89% hormone specific thyroids, and 85.9% adrenal efficiency. When you put it in a nice scheme, you see that 63% of the patients are fully panhypothyroidism. And you see the different connections between what has fallen out in the different patient groups. We also asked the patients what their most important health problem is. And fatigue and obesity really stands out. But also 20% of patients, visual problems, diabetes insipidus also with 25%, mood changes. So that's a real, and we also see that from patients reporting it to our patient organization. Fatigue is almost always number one, and obesity is also a very big problem. We also asked the children, what do you need help for? And you see that the children don't need help for food and diet, but they do want to have help with moving, exercising. They also want psychosocial assistance. And when you compare that to the parents, you see something different. You see that parents need help with food and diet, also for exercise and sport, and also psychosocial assistance. And what you see here, what you're still not seeing, is also help for study. And you can see the difference in parents and children. It's nice to see that there are differences, but also some things are the same, like psychosocial assistance. Also, we ask what the patients found from the help of the guidance from the endocrinologist. And it is good to see for the endocrinologists here present today that a lot of patients find the help excellent, of good to excellent. When we ask the same question for, and that's under my, that's something I did.
We can see the slide comparing the endocrinologist to the psychologist on the screen now.
And I don't see it anymore. Why don't I see it anymore? Something strange going on with my screen. I don't know what it is. I can't get back to my presentation.
We still see it.
Okay, well.
Would you like me to switch?
No, I have them also on my telephone.
Okay.
I don't know what it is. Yeah, you see that they're also very well. The help from the psychologist is not enough for the patients in 20% of the cases. And when we go to the next one, does it work? The next one?
No, we're still on the slide comparing the endocrinologist and the psychologist side by side. What do you think of the guidance or help you get from them?
I don't have them anymore. I see a screen, and that's it. Oh, there it is. Yeah. Okay. We also asked for the help of the dietitian, and you see that over 20% of the children of the patients said that the help is insufficient, but also 30% said it's not applicable. And we also asked the question for the oncologist, and that's of course not applicable in a lot of cases because maybe they only see an endocrinologist. We also asked if they missed anything in the treatment, and you see information is a very big part, 80%, but also help in diet and weight. And as seen in the previous schemes, you also saw that a lot of patients said psychological support is also very important. What we do see is peer support only 2%, and that's something that the patient organization offers. So that was a bit disappointing for me as a patient representative. Also, we got some remarks that some parents needed to quit a job to give care to the children. And also the problem that not all medicines are reimbursed, or people were not able to pay for the medicines needed. There is lack of general information. And also some patients said that doctors should aim for a more holistic view of the patient's situation. And parents, that's one nice, when you split the peer support, parents need to have more peer support than the children want. And one of the things also patients said is how to cope with tiredness. That's also a big problem for a lot of the patients. Well, looking at the survey, we had a few challenges, and already said it, that lacking patient organization infrastructure in a lot of countries hinders to find the responders for our survey. And especially reaching out for patient populations in Eastern and Southern Europe was very difficult, although we had a lot of translations available for them. Also, what's very important is you have to find the right HCPs for reaching out to the patients. But then it would be difficult to counter the ethical boards which are needed before a survey can be sent out to patients. So we had a few examples of that. It was also difficult to disseminate it via the healthcare providers. Also, finding the relevant native speakers to help with the translation and dissemination process would be difficult, but we could use the Endo-ERN network and finding the patients and the HCPs to help us in this process. Also difficult is to formulate questions. We think of questions, we translate them in all different languages, but it's very difficult to take into account the cultural differences in interpretation of the questions. So that's also difficult to do that and to find the right words to serve all patients. And what's also very difficult sometimes is that you have to find the right patients within an organization, patient organization. We have a pituitary organization, but only a small part of them are pediatric and hypothalamic patients. So how to fine-tune the targeting process to find those patients. And well, I said it already, the lengthy and elaborate ethical procedures and the difference between countries also hinders a fast and smooth process for disseminating and also making a survey available. Also, the patients gave some proposals for future research, and one of the things we heard was hormones without an injection would be very fine. The hydrocodone pump administration is also mentioned a few times. And also one of the children said pituitary transplantation would be a good idea, or an artificial pituitary gland. And also, you see it in diabetes, and continuous monitoring process for cortisol levels to prevent an adrenal crisis would be very welcomed. Also, a few said efficient regeneration would be very nice because some patients suffer from vision loss because of their craniopharyngioma. And also ways to tackle acquired brain injuries. People suffer of having a condition and they have a lifelong condition and they really want to find a solution for that. And also some said, well, an alternative way to draw blood, that would be very welcome for us as patients. I would like to thank the Wilhelmina Children's Hospital for giving me the opportunity to make this survey, and especially Isella van Roessel and Hanneke van Santen, who helped me with every aspect of this research project. Also the Endo-ERN's Maintenance Group, Pituitary, Hanneke van Santen and Evangelia Charmandari, who helped me. A special thanks also to the Hypothalamic network in Germany, Petra Broekman, who helped me with a lot of aspects of making this survey. My own organization, and also the British Pituitary Foundation for reading if my questions were English enough. And also the Endo-ERN EPACs and the Endo-ERN healthcare providers for helping me in the process. This concludes my presentation with some technical issues.
Well, despite the technical issues, thank you so much for your contribution. And well, I think the content is really innovative, and it's so important to see the patients' unmet needs and aspects that we are not realizing in outpatient care all the time. For example, that parents need to quit their jobs, and it has a lot of impact on the social system, etc., etc. The questions will be for later. First, we want to listen to the presentation of Sebastian Neggers. He is an adult endocrinologist from the Erasmus Medical Center in Rotterdam, the Netherlands, and his focus on research is on pituitary disease, especially acromegaly and familiar pituitary disease, long effects of treatments in this field, also long-term effects of childhood cancer and the metabolic parameters, and then also the metabolic disease like diabetes and obesity that is, of course, also in conjunction with growth hormone diseases and ghrelin. So, Sebastian, the floor is yours. You're muted.
So now you hear me, if everything's okay.
We can hear you, yeah.
Yeah, good. As I see, you can probably see my screen. So the question was if I could give a presentation about GLP-1 analog for hypothalamic obesity, and a little bit more specific, of course, for craniopharyngiomas, but also a little broader. I cannot move my slide. Oh, now I can. So these are my disclosures. I want to make it a little bit broader because if we're going to talk about GLP-1 and hypothalamic obesity, if you go through the clinicaltrials.gov, you're a little bit disappointed by the amount of trials that have been conducted. And if you try to find outcome data, they're very limited, but we'll get to that a little bit better later. But first of all, I think it's important to know how to assess obesity. And then we'll go to treatment of obesity and talk a little bit about surgery and GLP-1 analogs. And I will try to explain how we got into the field in Rotterdam to the surgery part, which Hanneke already alluded to a little bit. So most of us will use BMI to assess obesity. And alternatively, or maybe at the same time, we'll look at waist or waist-hip circumference. And some of you might look at bioimpedance and skin fold, maybe some, but it's not that common. And if you have the possibility and the funds, then probably some of you might also do assessment by CT, MR, or DEXA. And I will talk about the differences and where you should look out for. I think since we're looking at a group of patients who have an endocrine disorder in general, this means that their body composition might be a little bit different than you expect. And I think this is the most striking picture. Both patients looking at BMI, or both individuals and maybe, might look like they're obese because the BMI in both cases is 35. But I hope you agree with me that the individual on the left side is probably not really obese, while the one on the right side is. Although with the BMI looking at length and body mass, there's a difference. There's no difference. So what some of you might know, but maybe not all, is that if you look in the general population at one of the golden standards, namely the DEXA scanning, and you look at fat percentage versus BMI, that in the general population, about 40% will be misclassified if you use BMI only. And with the DEXA scan, you will pick them up. The question is if in craniopharyngioma, for instance, this will also be the case because, as Hanneke already pointed out, and also the first speaker, many of your patients will already be near or more or less obese. So here you see two graphs. The left one is the DEXA at the beginning, and the right one is at the end of our study, which we did. And you can see in blue males, and in red you will see females. So if you classify your patient correctly, for normal BMI, he should be in this area. So that means, I don't know if you can see my arrow, but that means in the left corner, left under corner, and for the males. And then if you correctly classify them as obese, they should be in the upper corner on the right. But you will see that in the, let's say, right lower corner, some of the males, but also some of the females are there, which are, according to BMI, not obese or not overweight, but with the fat percentage by DEXA, they are. So you're actually misclassifying with BMI about 23 of your patients, and especially the ones who are in a more or less normal area. So the patients with clearly elevated BMI usually are also clearly obese according to the DEXA scan. You can do it in a different way, and then you can look at fat mass index, which you can also assess and calculate via DEXA scanning. Here you more or less correct for the length, and then you see that BMI and fat mass index correspond better. But again, you're correct here for length, and I think probably absolute fat mass is a better way of looking at your obesity than at the fat mass index. So let's switch gears now. So we talked a little bit about how we can assess obesity. Now we can talk about treatment. And as you know, there are two more or less treatments available. I'm not talking about some of the things where you can increase energy expenditure, because Hanneke has talked about that already, but we'll start with surgery. And to be honest, I think it's a little bit more than a decade ago, probably almost 2 or 1.5 at least. One of my patients came back after a few months, and I hardly recognized this lady. And the reason for it was that she underwent bariatric surgery without, consulting me, or the surgeon who did it didn't consult me either. He just did this procedure. And probably if he would have asked me, I wouldn't have been a big fan of it, because the data which was out there, which was really scarce, didn't look very favorable. So now I will show you some of the data which is available from the 2 largest studies in individual patients on bariatric surgery. So just for everybody to keep this in mind, what the average efficacy is of bariatric surgery in common obesity, and then depending on which way you want to decrease food intake, by bending or by gastroplastic or by gastric bypass surgery, you'll have a different outcome. But in general, this gastric bypass surgery is the most effective one, and you need to keep in mind that especially in the first 2 years, the biggest decrease in weight can be observed. But then after 5 to 10 years, you see a kind of leveling off of the efficacy. So in general, after 5 to 10 years, especially after gastric bypass surgery, you have an efficacy of somewhere between 25 and mid-30ish%. What is maybe even better is if you look at, for instance, diabetes, the disappearance of diabetes or the recovery, then you see that compared to a lifestyle intervention, that even after 10 years, you have about 3 times as much recovery of diabetes compared to lifestyle intervention. And at 2 years, as you might expect, it's much higher. It's even 4 times higher than to lifestyle intervention. So although we don't like to say this, but I think this shows that surgery is a very effective treatment of common obesity. So these are the possibilities. So you have the sleeve gastrectomy and the Roux-en-Y gastric bypass, and this is the most commonly used one, the Roux-en-Y. But we have also some patients with craniopharyngioma who underwent sleeve gastrectomy. So here you see two studies, and of which one is very recent. So the left one is our international study we conducted in 16 patients with bariatric surgery. And on the right, you see the French study, which was recently published, looking at around 32 patients or 34 patients also treated by bariatric surgery. And I think in both cases, you see more or less a similar result, that your patients with craniopharyngiomas do quite well. Now my slides are gone as well. That's interesting. See if I can get them back. Yeah, got them back. And you see that patients with craniopharyngoma have a decrease over up to 5 years, somewhere between -10% in body weight loss to -25% in the French cohort, and in our cohort, it's in the high 10-ish%, so close to 20% to 30%. So I would say it's comparable, but controls, so the common obesity, do better, that's for sure, but you still see some effects in craniopharyngioma patients up to 5 years. If you split it into the type of gastric bypass, or the kind of bypass surgery, you can see that here in the Roux-en-Y, the more classical way of doing the bypass surgery, that the efficacy is somewhere between 20 and 30% in our cohort, and quite similar again, although the margin in the French study to, let's say, no reduction is a little bit smaller. So there you see like -5 to -20% in weight control or loss after 5 years. And the sleeve actually doesn't do that bad, and especially if you compare it to controls. And in some cases, like in the French study, although the numbers are limited and there's a lot of overlap, at least you have similar efficacy compared to control, but at least it's not worse than control compared to the Roux-en-Y gastric bypass. So I think from these studies, it shows that bariatric surgery might work. And again, like Hanneke said, most of these patients were adults, or young adults at least. There were no children included in most of these studies. There are some case reports that describe, let's say, teenagers who undergo this kind of surgery. But I think that the data which is out there mainly focuses on adults. But the downside, of course, could be that of all the hormone replacement you're giving them, it won't work that well anymore, or even you need to increase these doses. But the study that has been done by the Austrian group, where they really looked at the absorption of hydrocortisone, for instance, doesn't show a big difference before or after bariatric surgery in the uptake of most hormones. So in general, you can say that it's safe about replacement, and you don't need big dose adaptations. But you need to be aware that sometimes in some patients there can be some issues. So now we'll move to the GLP-1 analogs. So I expected a little bit more. I knew there were, let's say, 2 really beautiful studies assessed in around 40-ish patients with hypothalamic obesity, in which they gave exenatide. But if you look at clinicaltrials.gov, you only find 4 studies. And of those 4 studies, only 2 have been published. And of one, there is a little bit of data available on clinicaltrials.gov, but the other one, there's no data at all. So I think in general, the data which is out there is very, very limited. So these are the two big studies. They have both been done by long-acting exenatide, so it's a little bit similar to what Hanneke has shown you. And they looked at weight loss, and so that's mainly the left study, the study by Roth, and the study by Shoemaker on the right. That's the one that also looked at energy expenditure. So if you look at the data, so you see the study by Roth that a reasonable amount of patients actually decreased in BMI compared to placebo, and if they decreased also mainly in body fat. So that's a reasonable result, I would say. If you look at the right, by the study by Shoemaker, they also looked at energy expenditure. And the downside of the treatment with exenatide was that energy expenditure went down. And as you have heard before by the other presenters, energy expenditure itself can already be a problem in craniopharyngioma patients. So in these cases, it decreases, and it decreases more than you expect looking at their body at the body weight. So that's an additional problem. So if you would take that into account and think about the GLP-1s and bariatric surgery, I think that my take-home messages will be that bariatric surgery seems to be effective, not as effective probably if you compare it to the general population or to the common obesity. It is safe regarding replacement therapy. I think that's very important to know. The GLP-1 which have been given are the older GLP-1 analogs. They have been given in high doses, but they have limited effect. So you do see some reduction in body weight, but it's limited. And the most prevalent result they see is that you don't increase in body weight anymore. Most of the patients who were put on the GLP-1 analog were already like 8 years after the diagnosis. And as you know from the data, is that most of the patients actually gain weight quite rapidly after the surgery or even before the surgery in some cases. So maybe an earlier intervention might have more effect for a GLP-1 analog. But to be honest, and that's just my personal opinion, is that the current GLP-1 analogs which are available are probably will have still limited effect. And that's probably because of the energy expenditure together with the effectiveness of the current GLP-1 analogs. And if the new ones come around where there's a combination of GLP-1 analog and glucagon, for instance, or other combinations, those might be more effective in patients because you target more than just one area. And of course, for both, for surgery and for GLP-1 analogs, there's limited long-term data, although for the bariatric surgery, we have now data up to 5 years. And as I've shown you in the common obesity, 5 years more or less represents what you can expect on the long term. So it looks like bariatric surgery might have a place, although you should be very careful in which patients you will select for this procedure. So with that, I would like to thank all the people who helped us putting all these data together. And if there are any questions, feel free to ask them. Thank you very much.
Thank you so much. So we have now, for this very, very nice talk, we have now time for questions, although we are running a little bit late, but I think it's good to be interactive. My concern is I'm not sure the chat is working for the audience. Amy, can you tell us the situation?
Yes, there is a question box present, and I do have a question for you, but if people would like to raise their hand, I will also call upon them to ask their question directly to the presenters.
Okay, so I think we have
Can
a
I
first
kick off with a question, maybe?
Sure.
Well, just to make the conjunction between the pediatric talks and the adult talks, and Hanneke, you mentioned well, a nice workflow of how we could deal with this group. In my clinic, I think in the adult setting, the hyperphagia is less pronounced. I'm curious to find out, Sebastian, Johan, is that indeed well, the other experience as well? And do the adult caregivers expect that SHEAM, as well, starts to be developed in the pediatric scene, is going to work for the adults?
Well, maybe Nienke, if I may comment, I recognize what you say, that in the younger children, the hyperphagia can be much more present than in the older children. So often when I transfer them to the adult clinic, the hyperphagia seems to be somewhat more controlled. And I always wonder, is it because they've learned to live with it and they learn how to control it, or does it really diminish? And I think that's really interesting to look into together. I sometimes see that this craving for food changes in like a craving for shopping or other ways of hoarding. But yeah, I'm very interested to hear this from the adult endocrinology.
Can I make?
Oh, sorry.
No, I was just going to say, just linking on from what Hanneke was saying as a pediatrician, I think there's definitely a correlation between the severity of damage in the sense of clinically. So the children who are most disabled often seem to be the ones that have the worst hyperphagia. And I think that's just a clinical correlation between how much of the hypothalamus is damaged, really. Yeah, but I quite agree with Hanneke. I think the adolescents who are less, the hypothalamus doesn't appear to be clinically as damaged, do seem to get better in terms of their appetite. Sorry, Sebastian.
No, it's fine. No, I think in general, even the adults who get at adult age their craniopharyngioma tend not to have hyperphagia either, and even if they have very large tumors. So I think it's you see it more in pediatric cases, but also cases that started at pediatric age. So that's very important. And the other point, I think, which is very important, to be honest, the patients I struggle the most with are usually the patients with additional deficits, with neurological damage, and also with, let's say, a different or less socioeconomic background. Those are the ones who are much harder to instruct than the average patient. So if you have a combination of these two, then it's very, very hard. And then even in those cases, I think you should be aware that maybe if in these cases you shouldn't think about bariatric surgery, because there are some rules you need to live with, and bariatric surgery is not the holy grail we're looking for.
Irène, could you add something, or do you have experience?
Who are you asking the question to?
Yeah, Irène?
Yes.
To you, or to Johan, but to you. What do you see in France? Do you have other challenges?
No, I was wondering also, how is it linked to the type of surgery? Did you try to look into this?
Yeah, so we looked at the difference in obesity in general throughout the time, because if you look through time, especially in our center, but I think it's in all the European centers, that gross debulking has diminished, and now debulking with sparing the hypothalamic area and sparing as much structures as possible has become standard. And if necessary, we give radiotherapy thereafter if there's regrowth. And what you do see is that with the current treatment algorithm, so where we are less aggressive with surgery, you see less obesity. And that's quite striking, because you would expect more obesity looking at the general population at this time than 30 years ago. But in the craniopharyngiomas, you see less. So I think, yes, the type of surgery, the type of treatment we give now, and maybe it's also the replacement treatment, which is also has changed. But I think in general, you can say we are doing a little bit better, not perfect, but a little bit better looking at obesity.
Thank you. Do we have any question from the audience?
Can I make a short comment and question?
Sure.
It's Gudmundur here. So I just want to congratulate you with these excellent presentations. But I also want to stress you a little bit on I was quite surprised to learn that the side effects of GLP-1 analogs is so much higher in the pediatric setting than in the adult setting. And I think you alluded to the possible explanation in the hypophagia, but I'm interested to hear your thoughts about that, particularly you, Hanneke, because I was striking to hear this major difference.
Yeah, thank you. So it surprised me too, actually. And the patients report very much the nausea feeling, which they really didn't like. And I think it's due to the delayed gastric emptying, and they have this upbrowsing feeling the whole day, which was the most common reason actually for some children to stop their treatment. And it also interferes, of course, the patients are using hydrocortisone, and they're so used when they're feeling nausea to increase the hydrocortisone dose. So that was very difficult for parents and patients to accept nausea. Well, this is something they never accept because then you increase your hydrocortisone. So I think it was also mentally difficult to accept these feelings. I mean, I think maybe that adults can more easily deal with these feelings of nausea as side effects.
Thank you.
And the role of growth hormone?
Yeah, but so the injections is not really a problem. So they use their daily injections of growth hormone. So the fact that it has to be injected wasn't the main problem, I think.
But adequate dosing of growth hormone, you mentioned that you think it's quite important for the energy expenditure and the metabolic makeup, or?
Yeah. Well, yeah, but you know, it's often disappointing when you start your growth hormone treatment. You hope that it will decrease your weight, and so I think that's disappointing. But I do think it helps. So we shouldn't postpone growth hormone treatment in craniopharyngioma patients because they've had a tumor. I think it's a low-grade tumor. I think we have a lot of data that it's safe to start growth hormone if you're growth hormone deficient. So that was my main point. You shouldn't postpone it.
Yeah. What is the idea in adults, Sebastian? Can you comment on that?
Yeah, so I think Hanneke and I, but also Gudmundur, were part of this consensus statement, and let's say most of the adult endocrinologists, but also the pediatric endocrinologists, said that if you have a reasonable post-operative MR, post-operative MR, then you can start for sure. That means that in the vast majority of patients, 3 months after surgery, you can start with growth hormone. But maybe, let's say, it's a little bit less important in adults than it is in children, of course. But I think in general, we'll all start at 3 months, more or less.
And the combination with the insulin resistant and diabetes, of course, that can aggravate when you start on growth hormone, but it can also improve, isn't it?
Yeah, but actually that's a very interesting question, because Hanneke raised the issue that maybe increasing IGF-1 a little bit more, maybe in children this is a little bit easier than in adults, because if you bring an adult, especially in diabetic patients, the IGF-1 to the upper limit of normal, usually that means that you have a worsening of their glucose metabolism. So in adults, I would be a little bit careful, especially in diabetics. And probably, if you look at the English data from Duncan Dunnan, forgot his name, David, he quite nicely shows that if you go to median, more or less with IGF-1, especially in diabetic patients, it's better for the control of the diabetes and the lipids.
I think that's also a difference between the adult and the pediatric population. We don't see a lot of diabetes. Type 2 diabetes, we see it when they're 16, 17, 18, almost transferred to the adult clinic. So I think it's one of the differences, yeah.
Yeah, there was another question in the chat about how to measure the hyperphagia. Are we good in doing that, or is it still a challenge to make better, well?
I think it's a challenge, yeah, you know, and I think, so for this new score, we defined mild or severe by the way that it's a problem for the family and the parents. And I think asking this question when the parents are in the room, you will never get an honest question, or not never, but yeah. So, and there's of course the official, you have the Dykens hyperphagia questionnaire used for the Prader-Willi children. So there are some official questionnaires out there you can use. And I think if you really want to systematically assess it, we should use these kind of questionnaires. I don't know, how are you doing that in the UK?
Yeah, I mean, we don't routinely use questionnaires in the clinic, I have to confess. I mean, when I was doing my PhD, yeah, we were using the Dykens, but all of these are imperfect, aren't they? And it is dependent on patient and parent reporting. And even if you look at the Dykens questionnaire, their questions are quite subjective, that, you know, how much does your child's life get disrupted by food and that sort of thing. It's all a bit, you know, it really is family dependent, isn't it? So there are definitely some questions which seem to be much more discriminatory, as we all know. So, you know, if you're waking up at night to eat, if you're having to lock your cupboards, that sort of stuff, then that's fairly clear. But I think the more subtle degrees of hyperphagia are really hard to define. And, you know, when I did my research, I actually used the Dykens questionnaire on children with common obesity. And what was very interesting was that the scores were not really that different. There were some discriminatory questions, but actually your total score doesn't really tell you very much outside, you know, outside of the Prader-Willi setting. I think because even the way I think of it is common obesity is essentially a decompensatory hypothalamic response. If you didn't have decompensation, you wouldn't be obese. So in some ways, in many ways, all forms of obesity are hypothalamic in some ways. So that therefore a lot of the questionnaires we use probably are very hard to discriminate between those two forms, really. Not specific enough, I guess. Don't know if that answers.
Thank you. I have a question for Johan. You mentioned that in the survey, the patients are asking for more holistic type of medicine. So what do they mean by a holistic type of medicine?
Well, that's the problem of a survey, of course. They say as an answer they would like to have a more holistic view on how they are treated as patients. So a more integrated way of looking at the patient, but how and what specifics there isn't in place enough, because also I limited the number of words patients could be used in a survey. Otherwise you get prosa, and that's also very difficult to process, of course, in a survey. It would be nice maybe in the future to ask patients what do they mean and what do they want, maybe focus groups or whatever, but that wasn't the scope of this survey.
And
It
for
has to
the
be quantifiable. That was the most important thing. But we asked a few things to get a bit of the opinion and a bit of the spontaneous things children say, and that's also, we succeeded in it, but it could be more extensive.
thank you. But
I
for
think
the craniopharyngioma for specialists here, what would they add for an holistic type of medicine for the patients?
so maybe Johan, what I usually notice with patients with craniopharyngioma, but in general with rare disease, is that they feel misunderstood, especially if they also go, for instance, to a physiotherapist or to dentist, and
Dietitian.
maybe that's what they mean. And maybe I'm wrong, but I think that the problem is for them is that their rare disease in general makes them feel misunderstood at different healthcare providers, and therefore they would like to have a GP like we have a GP if we're healthy, who can more or less oversee everything, but they would like to have somebody like that as well who can help them out. And I think even for specialists like Hanneke or me, or for all of us, it's very difficult to really know everything about all the fields like dentistry or whatever with this specific disease. I think that's very hard.
It's not limited to children, because adults are also complaining about the same thing.
Yeah, well, there is a chat. I found it, and Cecile Brechet is commenting. Well, maybe that would be a great idea to start a ERN early intervention multi-aimed protocol with several modalities: methylphenidate, metformin, melatonin, maybe GLP-1. With the idea that we all start too late, because of course there's no evidence, and that we only start last resort drugs if everything has failed of lifestyle, etc. Would somebody want to comment on that? Hanneke, or Sebastian?
I think it's an excellent comment, because I think we see, well, at least in the kids, we see the BMI increase after surgery the first year, especially being huge. And I think we do start too late. So also with counseling, so in our hospital, we've really advocated that the dietary car, on the wards. So the first weeks after surgery, children are allowed to eat and drink. So we said, no, stop. We should start the day after surgery. It's water. It's not chocolate milk. It's teaching, education right from the start. And I think also, indeed, if there's an indication, we should start active treatment earlier and not wait until they're obese and then start treating it. Yeah. The question is how, but and with what, but.
Wow.
And also which patients.
Exactly, yeah.
I mean, if I can comment, one of the things, I guess it's maybe not early enough, and I don't know what your practice is like, but we've been starting metformin earlier in patients with not yet, not developed type 2 diabetes yet. They've got essentially insulin resistance, and in some of them, it does seem to make them lose weight. It's obviously not persistent, but they can show an initial fairly dramatic weight loss, and it's very hard to define which patients do that, but it's just an interesting observation we've had. But we do tend to start it earlier. I don't know if other people do that, maybe other people do it, but certainly in the UK, it's not common practice. Most people would start when they've got type 2 rather than kind of pre-diabetic states.
And so we do start in a pre-diabetic state as well, in adults at least.
Yeah.
I think the remark is spot on. But again, not everybody becomes obese. So you want to know who's going to become obese, and it's very. I think it's very hard also if you show a difference. Then let's say an FDA or an EMA will probably say, well, yeah, but only half of them or 40% of them will become obese. So you need a very large group then to show a difference. I think we need to come up with a good selection tool, and then, or maybe wait not 8 years like in the studies, but like, let's say, wait a year. And if you see a steep of half a year, and if you see a steep increase in BMI at that point, then start, because those are the ones probably who end up with severe obesity, I think.
Okay, so thank you very much. Do we have any more questions, or can we conclude?
Just
And,
one question. Just one
okay.
question came in about how about combining SGL2 and GLP-1 in the management of obesity? Has this been tried?
Well, I think it's a quite interesting idea, because you will lose energy by urinating, because you lose your glucose. I know that at least in the Netherlands, it's prohibited by the insurance companies to combine them, because they don't believe in the efficacy. So I never tried it, although I would like to. And I don't know how it is in the rest of Europe. I think that we'll run into some issues with reimbursement, because they're not registered to use together. But maybe in the UK, it's a little bit different.
Okay.
Sorry, I was trying to unmute myself. I have no experience of using SGLT2 in children. I guess my only concern is that in children who've got DI, where you're essentially causing a kind of osmotic diuresis, it's something to just think about, because, and quite often the patients with the worst hypothalamic obesity are usually ones with DI and adipsia and everything else. So that's my only concern. It's not licensed in children in the UK as well. So I think if we wanted to use it, we'd have to apply for special funding. But I don't actually know anyone who's used it. People are using GLP-1 mostly. But again, it's all on a case-by-case basis, really, and the response is really quite variable.
But I think this is an exciting period for this field, because we've seen with the first talk how complex the physiology of food intake is. But then we also see now that we are at the era that we can use this complex physiology to try new treatment and protocols, and a big hope for the patients, I think. So I think that's a very exciting and promising field. I don't know if Johan wants to make a conclusion after this talk in the view of the patients and all this new data and the hope there is in the new treatments.
We see a lot of people asking, also adults, not only the parents of children, for new treatments and medicinal solutions for treating obesity. But still, reimbursement is a problem, especially for, I don't know, it's in children, but in adults, there is a sort of waiting system and a sort of training to go before you get it. And we did have in our Patients magazine a few weeks ago an article on the medicinal treatment of obesity. And that was very well read, and people are very interested in those solutions. So it's always a question, it's always an issue. People are always talking about it. So future research would be very much welcomed, and also information on the outcomes of those treatments are very important to share with patients in a readable way. And that's a problem when you see some scientific papers, how to interpret it back to patients. That's difficult. And then we need your help to make that so.
Well, I think that's one of the promising things of Endo-ERN, the conjunction with the patients, the information sharing between countries, specialties, and with patients. So I think we are at the end of this session, and I would like to thank all the participants. all the presenters, Johan, Hanneke, Hongwei, Sebastian, thank you so much. My co-chair, Irène, and Amy for the organization.
Maybe
There will
Nienke,
be a next webinar, isn't it, Amy?
Say that again, sorry?
There will be a next webinar soon.
Yes, there will be. We have one planned for March already, and check out the Endo-ERN LinkedIn page or visit our website and register for our newsletter to be kept up to date.
Hanneke, you wanted to say something?
Yes, well, for those interested in childhood craniopharyngioma, we are organizing a postgraduate course on the 9th and 10th of March. So please, if anyone's interested, there are some places available. So the registration is open for that too.
Oh, thank you so much for pointing that out. Bye-bye.
Bye-bye.
Thank you from Endo-ERN to our speakers and chair. Good evening, everyone.